Today I'm talking to Professor Brian McKinstry. Now, Brian was well ahead of us because Brian has done a considerable amount of research on video consultations. Tell us a little bit about what you found with your research.
What I would say is that when we did get it working, it really worked very well indeed, that people liked it very much. They felt that the relationship they had with their doctor was quite strong with the video, that they felt that the doctor himself was more engaged in the consultation than they were when they were on the telephone. The doctors felt also that this was a better kind of relationship. They could see when patients maybe weren't understanding them properly. They could immediately see from the facial expression that someone wasn't understanding them. But more than that, they quite often just got the feeling that this person looked well or that they didn't look well, which is something you can't really get from a telephone consultation.
Apart from the technological limitations, there must be clinical limitations.
If we talk about the positive side of things first, certain types of consultation, like mental health consultations, are really, really well managed by video. Almost all the information that you would get from face-to-face, you can get on video. You can see, has this person put their makeup on? Are they, they washed their hair? Are they looking sad? Are they looking depressed? You can get all of that from the video. I mean, I think the drawback would have to be the obvious one, where you actually have to do a hands-on examination. So if you had to examine someone's abdomen, or listen to their chest, or perform a neurological examination, it is definitely more challenging to do something. You just can't do that. For the time being, I think there will still be people who need to come in and have a physical examination.
For some people, the technology may not be quite as accessible. Does this highlight social inequalities? Are there certain people who just can't quite cope with the technology, or don't have access to it, or perhaps can't afford it?
Yeah, well, there are. You've underlined all the different groups really that might have trouble with this. Many older people have smartphones, but they never use the smart features of those phones. So that's one group that I think may have difficulty with this technology. If they've got a relative, of course, at home with them who can help them use it, then that's great. And I think once you put the person in front of a screen and you've got the screen working, then it'll work fine for them, I think. The other group, I think, that might struggle with this are people who haven't got much money. And so to work these systems, you need to have a tablet or a telephone or with 3G, or you need to have Wi-Fi connected to these, or a PC with Wi-Fi as well. So the amount of data it uses is similar to a YouTube video. So like a YouTube video of 10 minutes would be what a consultation will use up. And a lot of people, they may own smartphones, but their data plans, because they can't afford contracts, they often cost quite a lot. And I think this is definitely a problem.
There are other areas of remote technology that you've been experimenting with on remote assessment. Tell me a little bit about what's happening in the future with remote assessment.
What you can get to work in a small experiment of 30 or 40 people, or in a randomized controlled trial where a huge amount of effort has gone into actually getting this to work, is a lot more difficult to get off the ground in real general practice. However, we have recently managed to produce a system which actually integrates really well with the workloads of GPs, providing them summary with blood pressures, and that they get either once a month, once every 3 months, once every 6 months, depending on how well the patient's controlled. Most people with COVID-19 are being discharged home from assessment centres, or being told on the telephone that yes, their symptoms are mild and that they should just manage these symptomatically. So what we've been trying to set up is a system whereby people will be able to answer a set of automatic questions every day by telemonitoring, and check their pulse oximetry twice a day and temperature twice a day.
Your work, which 18 months ago would have been considered experimental, really frontline research, has now become everyday general practice. It has completely changed the face of what we used to do. Brian, thank you very much indeed.
Thank you.